Dr. Mark Redding. He's the director of the Center for Bleeding and Clotting Disorders at the University of Minnesota Medical Center in Minneapolis. In his role, he's responsible for providing and coordinating patient care in the clinic and the hospital for all adult patients followed by the center, which is a federally funded hemophilia treatment center. In addition, he's associate professor of medicine in the Division of Hematology, Oncology, and Transplantation at the University of Minnesota.
My task is to review some basic clinical background of hemophilia and introduce some concepts about how we go about managing this condition. Toward the end, I'll speak to some treatment guidelines that help formulate our approach to the management of this disease. So hemophilia is a congenital bleeding disorder, which, unlike a lot of congenital blood disorders, affects all ethnic groups equally. For example, sickle cell disease and thalassemia are congenital blood disorders that affect certain ethnic groups, but hemophilia doesn't work that way. Hemophilia really affects all racial, ethnic, and socioeconomic groups equally. There are approximately 20,000 persons with hemophilia in the United States and roughly 500,000 worldwide. The severity of hemophilia historically has been categorized based on the baseline clotting factor level. So historically, we've said that severe hemophilia is present in those individuals with a factor 8 or factor 9 level of less than 1%. Mild hemophilia would be categorized as factor levels of greater than 5%, with moderate falling in between the two. The difference in these baseline factor levels correlates very clearly and very directly with the baseline bleeding tendency. Those with severe hemophilia would expect frequent spontaneous bleeding episodes, and the diagnosis in these individuals is virtually always made in early childhood. On the other hand, those with moderate and mild hemophilia may not be diagnosed until later in life. In fact, some of these individuals don't come to attention and actual formal diagnosis until they reach adulthood. So it's important to keep that in mind. Another thing I'd like to point out at this juncture is that although historically we've based our categorization on baseline factor level, it's being increasingly recognized that there are differences in the bleeding phenotype even in individuals who have the same baseline factor level. So for example, we may have two individuals with severe hemophilia A, both of whom have factor 8 levels of less than 1% at baseline, and yet when we look clinically at these individuals, we can see differences in their bleeding tendency and the consequences of having hemophilia. Similarly, some of the moderate patients who may have factor levels at baseline of 2 or 3% may have a bleeding phenotype which looks much more like severe hemophilia. And so the current approach to this is really to categorize people based on their baseline bleeding phenotype and not focus quite so stringently on the actual factor level. So the classic clinical manifestation of hemophilia is the joint bleed or hemarthrosis. The picture shown on the slide here is one of a young man with a right knee bleed, and what you can see from the photograph is that it's really swollen, but there's not a lot else to see. The point I want to make here is that what's going on inside the joint, the part that we can't see, is really something quite dramatic. It turns out that blood is a tremendously inflammatory substance, and when blood gets into a joint space, it causes tremendous inflammation. The result of that inflammation is the development of synovitis. The synovium is a thin lining of the joint. The cells of the synovium secrete the joint fluid, which lubricates the joint and helps keep the cartilage healthy. However, when the synovium gets inflamed, it hypertrophies, and the synovium is a very vascular tissue, and so a swollen, inflamed, hypertrophied synovium is at high risk for rebleeding. When the synovial tissue pouches out between the bony structures of the joint as shown in the cartoon, when the joint moves, those pieces of synovium can be pinched and then recurrent bleeding can occur. And so the process of bleeding into a joint causing inflammation, which leads to synovitis, which leads to recurrent bleeding, over time this causes tremendous destruction of the joint, and we don't see this in any other disease state except for hemophilia. This next slide shows an example of an elbow x-ray in a 36-year-old male that we followed at our center for many years. This right elbow, unfortunately, was a target joint in childhood, which means he had recurrent bleeding episodes into that joint. And over time, as you can see from the normal x-ray on the left compared to his x-ray on the right, the elbow joint here is really completely destroyed. We don't see any of the normal joint space nor any of the normal joint structures. So there's really a tremendously destructive process that occurs in the joints with recurrent bleeding episodes. This type of arthropathy then leads to significant physical impairment, impacts on quality of life, etc. Another clinical feature of hemophilia are deep soft tissue or deep muscle bleeds, and of course intracranial bleeds are also a feared consequence of this bleeding disorder. The panel on the left shows an example of an iliopsoas muscle bleed. This was a 52-year-old male with severe hemophilia B who had a spontaneous right iliopsoas muscle bleed. And you can see from the pictures here that the iliopsoas muscle is markedly enlarged. The one where the bleeding has occurred is circled. The arrowhead points to what a normal iliopsoas muscle would look like on these scanned images. And so you can see that there's tremendous increase in the size of the muscle. The amount of blood that you can put into this space is quite significant. Sometimes these patients will present with hypotension because of the amount of blood that's been lost out of the vascular space into these deep soft tissues. So these are very severe bleeds and require very aggressive treatment to stop and to ultimately control. Intracranial hemorrhage is usually the result of trauma. The CT images shown on the panel on the right side of your screen are from an individual who fell and hit his head on a curb. You can see on the top panel there, over on the right side, there's a little goose egg external to the skull. Internal, you can see evidence of intracranial hemorrhage. Now, this individual fortunately had factor with him, and within a minute or two of the trauma to his head, he was able to infuse himself, and this contained the bleed until he could get to the hospital and seek further attention. The photograph of the guy on the far right is a bit of a sad story. This guy had a similar episode where he fell and had some mild head trauma. Unfortunately, he didn't perceive that to be a significant event and didn't take any additional factor, and ultimately went home and laid down for a nap and didn't wake up from that, subsequently dying of a massive intracranial hemorrhage as a result of undertreatment of what was perceived to be mild head trauma. So intracranial bleeding is truly life-threatening, and even when managed aggressively, sometimes results in bad outcomes. So I want to shift gears for a minute and talk about inhibitors in congenital hemophilia. The issue here is that some hemophilia patients' immune systems will recognize the factor VIII or factor IX that we infuse to prevent or treat bleeding episodes. They'll recognize that as a foreign protein. When this happens, an immune response can be triggered, and the formation of antibodies against factor VIII or factor IX is the result of that. We call these antibodies inhibitors, and the significance of these cannot be overstated. These inhibitor antibodies neutralize the procoagulant function of the factor concentrates and render standard treatment essentially useless. The development of inhibitors is currently the most serious complication of factor replacement therapy. Now, these inhibitor antibodies are typically seen in those with severe hemophilia, although they do also occur in those with mild or moderate hemophilia. For reasons that we don't completely understand, the development of inhibitors is much more common in hemophilia A, affecting up to a third of individuals with severe hemophilia A. And in hemophilia B, it's much less common, with 3 to 5% of severe hemophilia B patients developing inhibitors. Again, we don't understand the reasons why there's such a difference in what appears to be the immunogenicity of factor VIII versus factor IX. The clinical consequences of having an inhibitor are that bleeding episodes are more difficult to control. The joint disease that these individuals suffer is really quite devastating, and the subsequent disability is quite severe. And these patients really create for us very major clinical and economic challenges. Previously, we thought that almost all inhibitors in those with severe hemophilia developed only after a few exposures early in life. Some more recent data published from the United Kingdom, however, demonstrates that inhibitor incidence actually has a bimodal distribution. So we see most inhibitors early in life, but there's increasing evidence and concern that with the aging process and subsequent changes in the immune system, inhibitors will be developing more commonly as individuals with hemophilia age. And this is just one publication that illustrates this quite clearly. So as our hemophilia population ages, we need to be ever vigilant for the potential development of an inhibitor antibody. And this will pose a number of additional challenges for us as we move forward in the next decade or two. So here's an example of clinically what it looks like to have an inhibitor. This is a slide that shows 3 x-rays from the same individual, and what I like to point out is that this guy is 22 years of age, so the very young age at which severe end-stage arthropathy develops in inhibitor patients is one of the key features. In addition, you can see the very rapid progression of joint disease. This guy in particular had a pretty normal-looking knee in March of 2008, and within about 2 years he'd progressed from essentially a decent normal-looking knee to end-stage arthropathy, which required a joint replacement. And so again, I cannot understate the significance of having an inhibitor in terms of the early age and the rapid speed with which the joint disease progresses in these individuals. So some of the unique treatment challenges for the inhibitor patients, again, standard factor replacement therapy is not possible because the antibodies neutralize factor VIII and factor IX. We do have agents available to treat these patients. We have recombinant factor VIIa, and we have activated prothrombin complex concentrates. These work fairly well, but they don't work perfectly. So if you look at the literature and if you look to our clinical experience, we see about a 75 to 90% efficacy rate in stopping acute bleeds. While that's quite good, the key here is that there are still 10 to maybe 20 or 25% of bleeds that we can't effectively control when we use these so-called bypassing agents. Another major challenge for us is that there's high degree of variability from patient to patient and even within the same patient from bleeding episode to bleeding episode. So we never really know for sure if the bypassing agent's going to work for this particular episode, and that causes tremendous anxiety for the patients and for the physicians alike. Another major challenge with the inhibitor patients is that prophylaxis is much more challenging. The activated prothrombin complex concentrate available in the U.S. is approved for prophylaxis, but the regimens are much less well established. They're less effective than in standard factor replacement prophylaxis, and there's a high burden due to the frequent large infusion volume that will be required for prophylactic treatment with activated prothrombin complex concentrates. Other challenges in treating inhibitor patients are that there is no established routine laboratory test to use to guide our dosing of the bypassing agents. There's the risk of thrombosis, which is ever present, and so these are really, really challenging patients to manage. A word about immune tolerance therapy. Immune tolerance therapy is the attempt to rid one of the inhibitor antibody. This is similar to getting allergy shots, where we would expose the patient over and over to high doses of the factor in the hope that over time the immune system would eventually sort of just give up and stop making the antibodies. So the goal, again, is to eradicate the inhibitor. This is attempted in all patients who develop inhibitors, essentially, but it's not always successful. You can see on the slide here that in our Hemophilia A patients, it's about 70% successful, whereas in Hemophilia B, immune tolerance therapy is much less successful, again for reasons that we don't fully understand. So turning now back to the non-inhibitor population, which is the bulk of our patients with hemophilia, how is it that we go about treating these? The cornerstone of our treatment is factor replacement therapy. When one is bleeding, replacing the thing that's missing is what always works best. So in the case of hemophilia A, we want to replace factor VIII. In hemophilia B, we want to replace factor IX. The plasma-derived factor VIII and factor IX concentrates were first developed and became available in the 1960s. Of course, as you all are probably aware, in the early 1980s, we saw the HIV epidemic, and contaminated plasma-derived concentrates were a huge problem, with many of our patients becoming infected with HIV and viral hepatitis. This was part of what spurred the development of the recombinant factor products, which were introduced in the 1990s. We do still use plasma-derived concentrates. They are now virally inactivated and considered safe, and so we have a lot of treatment options, which we're going to speak to in a bit more detail in a few moments. The recombinant factor products come in several different generations, first, second, third, and fourth. The basic idea here is that with the development of the subsequent generations of recombinant products, we see continued removal of animal and human proteins from the product. We see reduction in the infusion volume. And with the fourth generation products, there's the hope that these are potentially less immunogenic, although that's yet to be fully demonstrated. So in terms of giving factor replacement therapy, there's two ways to do it. We can treat our patients on demand, or we can treat prophylactically. On-demand treatment simply means that we treat a bleed when it occurs, and this is really effective at stopping a bleed after it starts. The problem with it, though, is that it doesn't do anything to prevent the joint disease that I showed you pictures and examples of a bit earlier. So on-demand therapy really isn't an adequate treatment for hemophilia in the long view. Prophylaxis, on the other hand, is the regular administration of factor concentrates with the goal of preventing bleeds from occurring in the first place and subsequently preventing the development of joint disease. The goal is to eliminate all bleeds. This was pioneered in Sweden actually in the late 1950s and really became standard of care once the recombinant factor products became widely available in the 1990s. Factor replacement therapy has benefits and challenges. The benefits of factor prophylaxis are, again, that it's proven to decrease bleeds and prevent the joint damage that we showed you before. Functional status and quality of life is also improved. In those who already have arthropathy before they start prophylaxis, there's accumulating evidence that, in fact, we can delay the progression of the joint disease with the institution of aggressive prophylaxis. And, of course, if you're taking factor prophylactically, you will also have some protection from traumatic and unexpected bleeding episodes. Challenges are still a big issue for us. Prophylaxis requires frequent intravenous infusions. This requires good venous access. And pharmacokinetically, what we see are peaks and troughs. In other words, every time you give a dose of factor, the level goes up, but eventually it goes back down. And so unless you're treating essentially every day, there are going to be periods where the factor level drops below the point at which you have complete protection against bleeding episodes. And so the frequent intravenous infusions and then how to maintain adherence to this kind of a regimen over the long term are the biggest challenges in factor replacement prophylaxis. So the goal, as I said before, of prophylaxis is to prevent all bleeds and subsequently to prevent arthropathy. Individuals with severe hemophilia will average 30 to 35 bleeds per year if they don't have regular factor prophylaxis. And inevitably, all of these patients will develop severe arthropathy unless they're treated effectively with prophylaxis. The mild and moderate patients are less likely to develop arthropathy, but I think the key point here is that they in fact can develop arthropathy. We used to think that it took multiple bleeds into a joint to trigger the process that I showed you earlier on that cartoon, but in fact we now know that only 1 or even 2 bleeds is necessary to start the process of inflammation and synovitis, which ultimately destroys the joint. So even our mild and moderate patients may be candidates for prophylaxis if their baseline bleeding phenotype is such that they're at risk for developing joint disease. So it's important to recognize that this isn't just for the severely affected patients. So this next slide shows sort of a menu of the hemophilia treatment landscape, and I don't want to spend too much time on this. What I really want to point out here is that it's quite complicated. So over on the left, we have the standard factor replacement products and the newer extended half-life products, and I'll speak to those in a bit more detail shortly. The goal here is to replace the missing factor VIII or factor IX, as we've been talking about. There are a lot of new therapies coming, so over on the right half of the table you can see some examples of some of the newer therapies. These work through very different mechanisms of action. We're not just replacing the missing clotting protein, but we're getting at trying to control bleeding in other ways, and these drugs have a lot of promise, and again we're going to speak to them in more detail shortly. One of the key things I'd like to point out about the non-factor replacement products that are here and coming are that they are not intravenous products. These are injected subcutaneously at frequencies that are much less than what we see with standard intravenous clotting factor replacement. So that's one of the major advantages. But similarly, there's a lot of other issues to consider. So some of the safety concerns with these newer products are things that we haven't seen in the past with standard factor replacement. And so there's a lot to be learned and a lot of new stuff coming down the pipeline. So this next slide just gives you a feel for how the hemophilia A treatment landscape has changed over a very short period of time. So with each year in the last several years, we've seen the approval of 1 or 2 more factor VIII concentrates. So the products listed there in pink are the new ones that were approved on those given years. And what you can see from this table is that in really the span of about 4 or 5 years, the number of products available to treat hemophilia A has essentially doubled. Similarly, with hemophilia B, we don't have quite as many products, but we have an awful lot of them. And again, there's a lot of new drug development going on in hemophilia B. So the treatment landscape for hemophilia is becoming increasingly complicated, in part because of the availability of more products, but also because of the availability of products that work through very different and unique mechanisms of action. So major unmet needs in the treatment of hemophilia. For our patients on prophylaxis, the major unmet need is how do we reduce the burden of prophylaxis and how do we help our patients maintain adherence to prophylaxis over decades. For the inhibitor patients, we really desperately for a long time have needed more effective prophylaxis and more consistent bleed management. So in the next few minutes, I'd like to spend some time reviewing with you some of the newer products that are here and some that are very soon to be here, we think, that begin to address some of these unmet needs. So we have extended half-life factor products, and we have some emerging therapies that we'll speak to. So extended half-life factor VIII and factor IX products are just what the name implies. These are factor VIII and factor IX proteins that have been modified chemically such that the half-life is prolonged with the goal of increasing the interval between infusions. So there are a variety of strategies that have been used to prolong the half-life of other drugs, and we've simply borrowed from those strategies and applied them to hemophilia. So the cartoon in the top part of this slide shows some of those strategies. We can attach FC, which is a portion of the IgG antibody protein, to factor VIII or factor IX. We can attach polyethylene glycol in a process called pegylation, and we can also attach albumin in a process called albumin fusion. So these are all strategies that have been used in other pharmaceutical areas to prolong the half-life of drugs, and they've now been applied to hemophilia. Again, the goal here is to extend the time that the factor VIII or factor IX circulates, which translates into a need for less frequent infusions. Down at the bottom of the slide, I've showed you here the degree to which half-life prolongation has been achieved with both factor VIII and factor IX. We're a bit disappointed with the degree of half-life prolongation with factor VIII. I'd say it's modest. Dosing intervals with the standard half-life products would be typically every 2 to 3 days. With the extended half-life proteins, dosing intervals range from about every 3 to 5 or perhaps every 7 days. So it's definitely an improvement, but it's certainly not as much of a dramatic improvement as we see with factor IX, where standard products would be dosed once or twice a week, while the extended half-life products with factor IX can be dosed every 1 to 2 weeks. So there's a very big difference in the degree of half-life prolongation between factor VIII and factor IX. The reason for this is that the half-life of factor VIII is dependent on another protein called von Willebrand factor, and so there's a sort of a biologic limit as to how much we can increase the factor VIII half-life because it's dependent on the half-life of a carrier protein. We don't have that issue with factor IX, which is why the same strategies can prolong its half-life to a much greater degree. So let's talk for a moment about some of the emerging therapies. The first one is emicizumab, which now has the trade name Hemlibra. This is a bispecific antibody which was approved in November of 2017 for treatment of patients with hemophilia A and inhibitors. It's not yet approved for non-inhibitor patients, although that approval is anticipated sometime in the fairly near future. So this is a very interesting molecule in that what it does really is replace the need for factor VIII. So the cartoon at the top of the slide over on the left side shows what factor VIII's job is in the clotting system. And when that is really to bring factor IXA and factor X into close proximity so that factor X can be activated and the coagulation cascade can continue. Emicizumab is a bispecific antibody, so one arm of the antibody recognizes factor IXA, the other arm of the antibody recognizes factor X, and it essentially does the same thing that factor VIII does, which is to bring those two proteins into close proximity so that factor X can be activated and the coagulation cascade can continue. So it's a very interesting, very novel and clever mechanism of action. So this drug again was approved very recently for prophylaxis in inhibitor patients. There's a loading dose of 3 milligrams per kilogram once weekly for 4 weeks, followed by a reduced maintenance dose, continued once weekly going forward. Again, this is subcutaneous dosing, not intravenous dosing, which is certainly favored by our patients. The clinical trials of this drug have shown very impressive reduction in bleeding in inhibitor patients when used prophylactically. I'd like to emphasize, however, that this is a drug for prophylaxis. We don't really think this drug is something that's going to be very effective for acute bleed management, and so we're still going to have the need for a way to manage acute bleeds that result, for example, from trauma in these patients. But nonetheless, this is really a very significant advance in the options for prophylaxis for those with factor VIII inhibitors. This is only for hemophilia A, not for hemophilia B. So moving on to some other emerging therapies, another concept, sort of a unique mechanism of action, if you will, to correct the coagulation deficit in hemophilia is so-called rebalancing of the clotting system. So the cartoon at the top of the slide here illustrates this. So under normal circumstances, the coagulation system is in balance. We have clot-making proteins and clot-regulating proteins. The middle panel shows what happens in hemophilia, where we have a reduced amount of either factor VIII or factor IX, and so the balance is tipped towards bleeding. Normally when we treat hemophilia, we add back factor VIII or factor IX to bring things back into balance. But there are new drugs in development that actually take the opposite approach, which is to take away some of the anticoagulant proteins to rebalance things that way. I think the mechanisms are a lot more complicated than this, but this simple way of looking at it at least illustrates the point. So there are several drugs in development. There's a drug called fitusiran, which is the furthest along. This is a drug that reduces the amount of antithrombin, which is one of the natural anticoagulant proteins. And there are at least 3 drugs in development which inhibit something called TFPI, or tissue factor pathway inhibitor, which is another regulatory protein. These drugs, unlike emicizumab, would be good for both hemophilia A and hemophilia B, so they have that advantage. They're also dosed subcutaneously at 1 to 4 week intervals based on how the clinical trials are going on. So there's a lot of promise from the early results of these trials. Again, these are drugs for prophylaxis, probably not for acute bleed management. So fitusiran is the furthest along. There was a brief hold on the clinical trial this past fall because of a thrombotic event. The trial is now reopened and moving forward cautiously. We do have concerns about some of these drugs in terms of manipulation of the regulatory pathways in the clotting system. There's some areas there that haven't been fully explored, but we assume at least one or more of these drugs will get approved sometime in the relatively near future. Just a quick word on gene therapy. Gene therapy is happening. This has been a very long process over more than 20 years. Suffice it to say that we've overcome many of the barriers to gene therapy, and now there are phase 2 studies in the U.S. actively ongoing for both hemophilia A and hemophilia B gene therapy. We don't know exactly when one or more of these may be approved, but I think everyone's in agreement that at some point gene therapy will become a reality. So the MASAC guidelines are an example of treatment guidelines which are in place to promote evidence-based care of our hemophilia population. There's another guideline that I'd like to point out to you, which we refer to as the NHF-McMaster guideline. So let's spend a moment talking about these individually. MASAC is the Medical and Scientific Advisory Council of the National Hemophilia Foundation. This group was created in the mid-1950s with the goal and the task of issuing recommendations and advisories on treatment, research, and other general health concerns for the bleeding disorders community. MASAC is composed of physicians and scientists as well as other medical professionals who have a wide range of expertise in the area of bleeding disorders, blood safety, infectious disease, etc. In addition, and importantly, I think MASAC also comprises the chairs of the NHF's nursing, social work, and physical therapy working groups, as well as consumer input. MASAC typically meets twice a year to issue treatment recommendations, which are then sent on to the NHF Board of Directors for ultimate approval and then dissemination. Over the years, MASAC has issued more than 400 communications covering a very wide range of medical issues, from prevention and treatment to infectious disease complications and so on. There are guidelines with regard to women with bleeding disorders, so just a very rich amount of very good information and recommendations about how to manage those in the bleeding disorders community. Each year, MASAC establishes some standard treatment guidelines, and these are the guidelines that are often referred to by international experts, pharmacists, ER personnel, and importantly, insurance companies. New MASAC documents are announced periodically in NHF Notes, which is the monthly e-newsletter from the National Hemophilia Foundation. These documents are always available through Handy, which is NHF's Information Resource Center. And the link at the bottom of the slide here will take you directly there. So a really important and valuable resource of which we'd like you to be aware. Here's an example of a MASAC guideline. This is Guideline 132, which outlines standards and criteria for the care of those with congenital bleeding disorders, and it really just speaks to the types of services that need to be available in a hemophilia treatment center. So we have a wide range of diagnostic services, education and outreach services, etc. This guideline also speaks to some of the key elements of the facility in terms of what it really takes to have a comprehensive bleeding disorders treatment program. Lastly, I'd like to just point out the NHF-McMaster guideline. This is a very important document that was recently published. You can see the reference down below there. This is an evidence-based guideline and includes a systematic review of all of the current literature and data. This guideline very strongly speaks to the notion that integrated care models should be used over non-integrated care models. This recommendation is particularly important for those with inhibitors or those who are at risk of developing inhibitors, and so it's just really key to understand the importance of this type of care model for those most challenging patients. But I would argue that all hemophilia patients really ought to be cared for in this manner. The guideline gets into some of the details about what comprises the ideal or the optimal integrated care model, specifically calling out the presence of a hematologist, a specialized nurse, physical therapy, and social work specialists, all of whom have expertise in hemophilia. These people should all be part of the integrated care team. In addition, ideally, round-the-clock access to a specialized coagulation laboratory is another key component of the integrated care model. So I'd encourage you to take a look at this guideline. It's got a lot of really valuable information, and again, this is evidence-based, includes a systematic review of all the current data, so quite a valuable document for us. So in summary, I've covered for you some basic clinical aspects of hemophilia. We've talked about the basic treatment approach, some of the challenges and limitations of our treatment approach, and some of the new therapies that are on the horizon. We talked about patients with inhibitors, and aside from the development of inhibitors, hemophilic arthropathy, which really all of our patients are at risk for, is a significant potential complication. In order to prevent arthropathy, we need to have strict adherence over the long term to prophylactic factor replacement. Some of the newer and emerging treatments are beginning to address some of the challenges and barriers to effective prophylaxis, and also to offer more hope for those with inhibitors who have been in desperate need of better therapies for many years. The optimal use of all of these new and emerging treatments for hemophilia has made our clinical decision-making very complex, and I think really underscores the importance of patients with hemophilia being cared for in a hemophilia treatment center following the integrated care model as supported by the guidelines and documents that we just referred to. The treatment guidelines and evidence-based recommendations are very helpful in assisting us with our clinical decision making and with the overall delivery of multidisciplinary integrated care really being the gold standard.